So I'd like to invite Professor Takefumi Yamaguchi. He's from Tokyo Dental College in Japan. He's a very nice, great corneal surgeon. And he was talking about corneal aberrations in corneal ectasias. Can you start your talk?
Thank you. Thank you for this great opportunity to talk about corneal aberration in ectasia. I arranged my talk that I believe that fit to Indian country because I think in your country infectious keratitis is the incidence of infectious keratitis is high. So the other percutaneous keratitis that affects the younger generation. So I believe ectasia is not limited to keratoconus or post-LASIK, but it can be seen in various corneal diseases. And I'd like to show you the my data. So corneal ectasia is defined as a progressive stiffening and thinning of the cornea. In general, it includes keratoconus, post-LASIK ectasia, and periusido-marginal corneal degeneration. In 2018, I found an interesting article from India. It's on corneal ectasia in Stevens-Johnson syndrome, written by Professor Sharma. When I read this article, I wonder if it's really ectasia. However, Professor Sharma beautifully demonstrated fulfilling the ectasia definition by showing corneal stiffening, anterior-posterior elevation, and corneal thinning in this article. Since I read this article from India, I have been working on this topic, corneal aberration in ectasia. I feel like destiny talking on this here in India, especially in AIOS chaired by Professor Sharma. Today, I'd like to talk about following topics. First of all, I'd like to ask you a question. Can ectasia occur in other corneal diseases? Answer is yes. For example, ectasia occurs about in 10% in eyes after infectious keratitis, as shown here in these slides. You can see corneal stiffening and thinning in eyes after bacterial keratitis. It happens in eyes after fungal and acanthamoeba keratitis. Not only after bacterial, fungal, acanthamoeba keratitis, ectasia can occur after herpetic stromal keratitis. This case reports from Germany showed keratoconus-like tomographic changes in eyes after recurrent stromal keratitis. We also reported that ectasia-like changes occurs in about 10% after herpetic stromal keratitis, as shown here. How about percutaneous keratitis? It's in the infectious and herpetic keratitis. Ectasia-like tomographic changes can happen after percutaneous keratitis due to stromal melts and thinning in the acute inflammatory phase. Thus, we come to notice that keratoconus is not the only disease with corneal ectasia, but other various corneal diseases can exhibit keratoconus-like corneal shape in axial maps. But we need to be very careful about the definition of ectasia because there are two patterns in tomography maps, true ectasia and pseudoectasia. Not all keratoconus-like axial map are ectasia. As in this figure, corneal epithelial thickening causes localized red area in axial map that's similar to that of ectasia, but actually not. No signs of corneal thinning and posterior elevation. In addition, ectasia is defined as progressive disease. Keratoconus-like axial map changes in various corneal diseases may not be progressive, but it's true in keratoconus too. So not all keratoconus are progressive. I think we need to reconsider the definition of ectasia. So next, I'd like to talk about corneal aberration and clinical importance and relevance in relation to visual acuity. Coming back to Professor Sharma's article, in this AJO article from India, one of the important findings is that the K value was significantly correlated with visual acuity. That is, the steeper the cornea, the visual acuity decreases in Stevens-Johnson syndrome. Using anterior segment OCT, Kaisia, Tome, we have published corneal aberration data and specific tomography patterns, including ectasia-like changes in almost all major diseases as shown here. And we found one important fact. That is, a corneal aberration increase in eyes with keratoconus changes. Corneal aberrations are significantly correlated with patients' visual acuity in all major corneal diseases except granular dystrophy. This suggests that measuring corneal higher order aberration in such patients is clinically relevant. But without any ways to manage aberration, there will be no clinical meaning. So next, I'd like to talk about, from the viewpoint of providing better vision for patients, how to manage increased corneal aberration in various corneal diseases. When we compare the amount of corneal aberrations among various corneal diseases, we will notice an important fact. These diseases are not only keratoconus, but also herpetic, bacterial, fungal keratitis, have large amount of corneal aberrations. This line represents the amount of corneal aberrations after penetrating keratoplasty. And the more the aberration, the patient visuality decreases. Don't you think it's like IOP in glaucoma? The higher IOP, the worse glaucoma condition becomes. Glaucoma specialists measure IOP in all types of glaucoma and decide eye drop, indication for glaucoma surgery. It's not true only in POAG, but they always measure IOP in all types of glaucoma, including NVG, non-tension glaucoma. So aberration in corneal diseases can be a biomarker as IOP, I believe. So the main message of my presentation is minimizing corneal aberration improves visual acuity with treatment such as contact lenses, PK, DAG, EK, like this. So in keratoconus, the purpose of the corneal transplantation is to improve visual acuity by reducing corneal aberration because its cornea is clear and transparent. However, in some patients, post-operative visual acuity is remarkably poor due to large amount of astigmatism like these patients. So not only regular astigmatism, these patients have a very high amount of irregular astigmatism, that is aberration. So the complaints, I cannot see at all after surgery. It's very pity for them. So reducing irregular astigmatism aberration is very important, and the pre-operative assessment is very clinically relevant issue. So in contrast, this patient has an excellent vision of 1.0 with minimum astigmatism. This is ideal course. It's not a miracle. It's if we perform penetrating keratoplasty in a good way, it's very possible. It's not impossible. So our study revealed that the visual improvement after penetrating keratoplasty was significantly correlated with pre-operative corneal aberrations. It may be confusing, but it shows that in patients with small amount of pre-operative aberrations, visual acuity improves a little by penetrating keratoplasty. But in patients with moderate to severe corneal aberrations, the visual acuity will improve a lot after penetrating keratoplasty. So based on the preoperative aberration, we can consider post-op targets, corneal aberrations, and indication for PK, like in glaucoma clinic. So although it's still controversial, I think, I'd like to show you how to minimize corneal aberration after corneal transplantation. So graft suturing or select EK, pupilloplasty, post-op suture adjustment. This is a representative Crohn's case undergoing penetrating keratoplasty. Pre-operative visual acuity 0.02, improved to 0.6 after penetrating keratoplasty. And this patient had a large amount of corneal aberration. So I adjust the suture, and his vision improved to 1.0. Graft suturing is also important to make the corneal aberration smaller. First, four sutures determine the. I would like to show the video. Can you put the video? Okay. The second suture is especially important. If it's secured like this, the tomography pattern after surgery would be like this, it's like a keratoconus. And third and fourth suture is also important. If we put sutures like this, the post-operative tomography would be like this. It's also like a keratoconus. In patients with iris defects and or decentered pupil, pupilloplasty is also improved patient vision because the amount of corneal aberration is in proportion to the square of the pupil diameter. I performed 6 PK combined with pupilloplasty. The visual acuity improved from 0.01 to 1.0 with small amount of corneal aberration post-operatively. So this is the last slide. Corneal ectasia can occur in various corneal diseases like infectious keratitis or frequentenular keratitis that affects younger generation. Corneal aberration can be a relevant biomarker to achieve best visual acuity for patients with ectasia like tomography map. Thank you for your kind attention.
So thank you for the wonderful presentation. Is there any comment or question from the audience? So can I ask a quick question? So your number, post-preoperative corneal high aberration number is derived from anterior segment OCT, right?
Yes.
Actually, I believe this is from Kasia from Japan. So have you ever tried with another machine?
Maybe Pentacam, using Pentacam, corneal aberration is available. However, in eyes with corneal opacity, preoperatively, Pentacam uses short wavelengths.
The blue light, yes.
Blue light. So preoperative assessment would be impossible using Pentacam. But post-op is okay.
Maybe you can try another anterior segment OCT machine from another company as well.
Yeah,
please.
I'd like to. Thank you for your comments.
Can I ask another question?
Yes.
You mentioned about the higher order aberrations in your decision making for surgery.
Mm-hmm.
Is that with the naked eye or even with the contact lens? Because like Shizuka showed that you can reduce the higher order aberrations by putting an RGP.
Mm-hmm.
Would you then do the surgery only if with the contact lens the higher order aberrations are high, or is it even without the contact lens that you?
Yeah. I think in both cases it's very useful. And in my hospital, there are many corneal fellows who run corneal transplantation. And for them, at first, their suturing is not so good. So I show the actual corneal aberrations preoperatively for them, and I advise them not to increase corneal aberration post-operatively if the patient has a small amount of corneal aberration. It's very important in the setting of education. Thank you. Thank you.